Good morning, everyone. My name is Harold Holder. I'm speaking to you from San Francisco, California. I'm sorry I will not be there in person, which will prevent two things. One is a chance for us to have questions and discussions, but the other is you will not be able to see the slides that I'm working from as I give the presentation. First, let me give you a little bit of background about my history. For about 30 years, I have been working in the area of prevention research, specifically working on strategies and effects and opportunities for preventing substance abuse problems, specifically with an emphasis on alcohol. One of the reasons that I have focused on alcohol is if you look across the world, in spite of the attention to illicit drugs and other concerns, alcohol and then tobacco become our two major problem areas. This is especially true for young people, which we'll talk about today. The other bit about my history that's important is I began work in prevention because I was working in treatment some many years ago, and we were working to get alcoholics who were being treated at the time out of the psychiatric facilities and into the community and to have recovery much closer to home. And one of the things I realized there is that alcoholics, we would always have a supply of alcoholics. But another very important realization was that problems associated with drinking were not just concentrated with those who were dependent. It also involved young people, particularly young adults who were heavy drinkers, and others who may not be dependent but behave using alcohol in a high-risk way, either in terms of high amount of drinking or drinking in high-risk situations such as driving an automobile or engaged in other activities. So it's that as a background that I want to talk about today. And my primary focus, I think, is to remind us and to bring to your attention that there is a great deal of science, knowledge now about strategies that can work both at a national level and at a local level. Since I've retired, I was previously a director of a prevention research center in Berkeley, California, and I've been focused on working with communities around how to bring science to practice. And I don't mean by that just learning about our findings in terms of what could work or couldn't work, but also some of the tools and techniques that we've used to evaluate and to monitor our work. So with that in mind, let me just remind you of things you should know. Alcohol, which I will spend much of my attention to, and smoking. Alcohol is particularly interesting or important because it alters behavior in the moment and increases what we'll call acute harms. That is the chance of falls, injuries, violent events, etc., including drink drive, if that is the case. Tobacco is a different phenomenon. Its long-term effects, which are substantial, go for a long time, and they extend into middle age and result in a lot of health care demands as well as early death. One of the concerns that all of us in prevention have about smoking is we are learning more and more about the early addictiveness of the substance, that it doesn't require a great deal of exposure to tobacco for kids to begin to become dependent or experience some withdrawal from either smoking or even chewing, using snoof, the newer suggestion, which is if you can just taste it, it's harmless. And that, of course, brings us into the area of throat cancers, etc. The other concern that I think I have about alcohol is the way youth and young adults in almost all of our countries use alcohol. That is, they drink to get high, they drink to have fun, they drink to do crazy things. And so that's a particular concern. For young adolescents, we're beginning to learn about how the adolescent brain develops. And as a result, we realize that alcohol can have some significant effects on the young brain as it's developing. And this goes along with the fact that the developing part of the adolescent brain between, say, the years of 12 and 18 is the frontal lobes, which are the area that has to do with being cautious, being careful, so that you get an increased intensity to take risk when you are drinking. Lest we forget, though, there are other substances that are important depending on the culture. Young people find many ways to get high, and that's including using petrol, aerosol sprays, paints, glues, magic markers, etc. So particularly for younger people and depending on culture, what we call inhalants are legal substances that have an ability to bring intoxication. So, just what is prevention anyway? For me, there are 4 goals or intentions of prevention. The first, and I believe the most important, is to prevent health and safety problems associated with substance use. And that includes traffic crashes, violence, lung cancer, overdose of substances, accidents, etc. So, taking a public health and safety perspective. A second goal is to delay adolescent initiation of substances that may be legal for adults, and that includes tobacco and alcohol. We now know from longitudinal research that the earlier young people began drinking and or began smoking, their likelihood of having problems with either substances later in life, including through their adolescent years and into young adult, is substantially increased. This is an area that has been newly begun to be developed in the alcohol research area, and as yet we are still figuring out how best to do that. But it's an important goal for us, delay initiation. A third goal is to prevent heavy and high-risk use of substances, and this is where adults come in, particularly for alcohol and tobacco. Smoking cessation for adults is a very important area, but also helping adults or dealing with adults who may not be dependent. So this is not necessarily a treatment intervention, but to work with the world so that the heavy use of alcohol in particular is reduced. And then the fourth area is to prevent all use of tobacco as a illicit substance, but also to prevent any use of illegal substances for anyone, regardless of their age. So, in summary, 4 goals: prevent problems, delay initiation, prevent heavy and high-risk use, and prevent all use of tobacco and illegal substances. Now notice that in my goals set, a list of programs is not taken to be the goal for prevention. To me, programs and policies and interventions are but tools, and they come out of our toolkit as we need them and as they are effective. So it is important that we always keep in mind that we are not in the business as prevention specialists in just providing services or providing educational programs. That's not prevention. That's taking action with the hope that you are being effective in prevention. And one of my goals since retirement, if you will, has been to work with communities to increase their ability to determine and to demonstrate their effectiveness. The point of view that I take, and many others take, is a public health perspective or model, which includes the famous triangle of public health, which is the individual, the environment, and the agent. And those 3 points interact as a triangle, but they also interact with each other. Notice that it's not just focused on the individual, but we're also concerned with the environment or the context in which substances are used, as well as the agents themselves. When one takes a look at these approaches, the individual approaches are focused on how to change individuals, one by one, if you will. These are using strategies that work directly toward the individual. I personally prefer and feel we have the best evidence and the best opportunity taking an environmental or public health approach. At this level, we're taking on the community as the client. And one of the perspectives that I think is rich for prevention is looking at substance abuse use and related harm as a product or result of the community or even the national system. In other words, we're working to try to make population level changes, not only or not targeting individuals as high risk only or our problem citizens, if you will. So what do we know about prevention? What are the things we have solid evidence? And I'm describing evidence at this point in terms of effects at the population level. What do we know can work? The strategy that has the greatest science base or research base is the retail price. This is particularly true for alcohol and tobacco as legal substances, but there is research evidence that illegal drugs, including cannabis, are affected by retail price. There are some countries, such as Sweden, Finland, or Norway, that actually purposefully use the retail price in terms of the stores that sell alcohol as a device to reduce the use of the beverages. In Canada, in my own country, the United States, there are retail monopolies that have that also as a part of the strategy. Another strategy that, or policy that has had great effect is a minimum age for drinking and or purchase age. We know a great deal about this in the United States because we have a very high purchase or drinking age in the United States across all 50 states, which is 21 years across all beverages and in all situations, both bars and restaurants and at stores and shops. We also have a high age for purchase of tobacco products, 18. In both cases, these purchase ages have been a very important policy for preventing harm. The minimum drinking age in the United States, which is one, if not the highest in the world, has now a number of years of documented evidence to show that it has reduced harm, particularly deaths and injuries to young adults and young people under the age of 21. Another strategy that's also used and is taken on some importance is the style and form of retail sale. That includes hours and days of sale. What days do you have shops open? There's a good bit of research that as you make alcohol available or other substances available longer hours during a week, you have greater consumption. And conversely, as you reduce the hours of sale, you have less harm. Another area, depending on how much drinking and driving is an important area, as it is for my country, but for many other developed countries, drinking, driving, deterrence and enforcement. This is a strategy that requires specific planning, one where you focus not on specific days of high-risk driving, but also across the time. That is what has been called, in some cases, a random breath testing. This is a strategy being used in some countries, particularly in countries like Sweden, to some degree in Finland, but also in New Zealand and Australia. The density and concentration of retail outlets has been increasingly shown to be related to harm, so that when you have a state-owned retail monopoly, you are by naturally going to have a lower concentration of alcohol outlets. And it's particularly a strategy of importance to communities because in most communities you have the ability to work with your planning and land use regulations, if you so desire, to lower harm. Just a comment on price. It is a common misconception that price has no effect on heavy drinkers, that the heavy drinkers or smokers will get alcohol and tobacco no matter the price. That isn't true. Heavy dependent and heavy frequent users of both substances are affected by price. And this is especially true for young people who have less disposable income to purchase. So therefore, as price goes up, they are actually more affected than adults. What are some strategies that look promising, need more attention? One that's been very popular, that has shown positive and promising effects, is what's called server training or responsible beverage service. What we know is that a lot of harm connected to drinking is connected to bars and restaurants and what we would call over-serving. So one point of intervention is to work with servers and managers of such establishments, usually through training, but also through establishing policies and other compliance. Some of it requires enforcement, some of it requires positive praise and support. Another strategy is community prevention trials, utilizing policy and environmental approaches. We need more replication. I'll talk about one that my center was involved in. Family education and mobilization has shown some positive effects, but primarily for parents who are willing to come to such training. There's a little bit of a selection bias there, so I would have to use that result cautiously. We do have in many countries warning labels on retail products, including alcohol, tobacco. They don't show much effects per se. They certainly are part of an awareness building effort to let people know that the products, though legal, do have risk, but there needs more study and more investigation. One approach to prevention that's popular around the world that needs to be spoken to, and that's using public education. Public education is unfortunately not a magic bullet, meaning it's a single approach will not itself reduce the harm related to substances. The evidence on that is pretty overwhelming. So the notion that our job as prevention specialists is to just warn people and young people in particular about harm isn't going to work. It's not going to be true. However, can education be used in some way to complement other strategies? And yes, they can, and we'll talk about that in just a bit. Another strategy that is often popular is using schools and educating young people. That's particularly been true in my country, in the United States. Unfortunately, the evidence of this intervention, which I happen to think as a parent and a grandparent is a good idea, isn't sufficient in itself. As I've often said, if young people live in an environment where alcohol is readily available at the shops, readily available from friends and family, school education is not going to have much effect anyway. So it's a useful, perhaps helpful, but not sufficient strategy. Looking at prevention from a community's point of view, one of the strategies that has been used more frequently across the world that I wanted to mention is what I'm going to call a comprehensive mix of evidence strategies at the local level. One of the cases that all countries face is that there are certain policies that are restricted to the national level, or in my case, state, or in case of, say, Canada, or regional level, so that the local community or neighborhood needs to find strategies that are possible within their range and within their scope. So there has been more and more studies trials, if you will, or research-based studies looking at how do you mix strategies at a local level in a way that can reduce harm. So I wanted to describe one that my center in Berkeley was involved in to demonstrate the possibilities that exist. Our trial was concerned with reducing alcohol-involved trauma, which included violence, falls, burns, and injuries, and traffic crashes. In the United States, drinking driving, because of the frequency, availability of alcohol, is a particular concern. The first part of our intervention was to get the community involved, and we call that community mobilization. And mobilization took two parts, which is meeting with community leaders and other interested people from agencies and organizations, as well as the government, perhaps to create a group or a coalition that would meet together on a regular basis. The other part of mobilization is very important. I want to mention that. And I mentioned earlier that education alone is not sufficient, but the use of local news can be. Local news can have at least two important roles in a prevention project. The first one is it can make the community more aware of the problems that it's faced in terms of substance abuse. So it is taking local data and saying this is what we are faced with and this is the harm and these are why we are concerned. One of the advantages to that kind of use of local news is that it can get the attention of elected officials or community leaders, whatever the form of government, in order to get them involved in our efforts. The second goal for using news is to inform people about strategies that would be implemented in the community that have real possibilities of being effective. So in other words, it's telling the community about the potential efficacy or effectiveness of strategies so that they can support them. In our case, we use local newspapers a great deal, and there were many articles, news stories, based on some of the evidence and the data from the community, particularly epidemiological data. One of the particular strategies that we emphasize for young people is what's often called compliance checks, since we have a very high sales rate for alcohol, a very high sales limit, for alcohol 21 years. Our task was to determine if retailers were actually selling young people without checking age identification, and if in fact they reduced their such sales after intervention. And in fact, we were able to demonstrate that that was the case. It did require, for it to be fully effective, a combination of enforcement, the threat of having someone be arrested or ticketed, given a warning if they were selling to young people, as well as training. We did conduct training of retail clerks and managers to help them with identifying and requiring age identification, not just looking at the person and saying, oh, well, you must be of legal age. Another part of that, as I mentioned earlier, is we used responsible beverage training, which worked with bars and restaurants on questions of how do you intervene, how do you cut off customers who may be drinking too much, who then could be involved in injuries after they leave the bar or restaurant. It was an important demonstration. It's one of the first in the United States where you could actually demonstrate that intervening at a community level actually reduced harm at a population level, not just a target group level. So the results of the project were we found that it produced about a 6% reduction in heavy drinking, about a 50% reduction in drinking after driving after drinking, and we were able to confirm that result by actually taking breath samples of drivers randomly along the roadside and we were able to find about the same reduction. That is, people were just drinking and driving too long, too infrequently. We also found that injury crashes were being reduced. These are crashes that have a lot of drinking and driving in the United States. But we also found that hospitalizations, particularly with young people and young adults, were declining as well, so that we got fewer and fewer of those cases. Overall, when Lund looks at this kind of work, it does require that the community does several things if you want to get effects like this at a population level. I think the first one is you have to select strategies that are have evidence-based. I do have some recommendations for considering going forward with prevention. The first one is that you should know that science-based prevention strategies do exist. They are not always popular, and they're not always easy to implement, but we definitely have solid evidence that they can be effective if appropriately implemented. Second, it's always important that we involve political leaders and elected officials, and that we use the local news so that the project, whatever efforts are intimately involved with the communities. A third recommendation is do not target subgroups alone. This is frequently a strategy, but target the total community environment. High-risk individuals in a community are affected by environmental strategies, in some cases maybe more so than others, and you do not have to, quote, identify them and somehow treat them or give them special attention to have overall effectiveness. The last point, which is the most difficult, I think, is always evaluate effectiveness. Now, notice I said at the very beginning that our job is not as prevention people to implement programs or efforts, but to really achieve effects, that is, to reduce harm. So always evaluate to determine if you're having that effects and to demonstrate if you are. So I would say that good science, therefore, can be good politics. I certainly would use every effort to reward our success and to reward success in our community, and to create ways to sustain our efforts that are working, what we might say in English, institutionalization, that is, make it a part of the institution of the community. Well, those are my comments for today. I hope you enjoy the conference. I regret I'm not there, and I certainly feel it to be a loss in that I am not there to have now a discussion and answer questions. But best wishes from North America, and I hope things go very well. Thanks.